You know, when it comes to complete dentures, we often wonder what makes the difference between a perfect fit and, well, a total flop. The secret, a lot of the time, is hiding in this one tiny, super important area at the back of the palate. Today, we're going to master a concept that is a complete game changer for denture fit, the Posterior Palatal Seal, or what we all call the PPS. Let's get right into it. So let me just ask you this straight up. When you're trying to get a maxillary denture to really lock in place, what is the single most important factor? I mean, we talk a lot about borders and how far they extend, but there's one specific zone that gives you that essential suction and totally completes the seal. And yeah, you're probably ahead of me. It's all about the PPS. Okay, here's our game plan for this explainer. First, we'll nail down what the PPS actually is. Then, we'll map out the anatomy you need to know. We'll cover why this seal is so darn important, and then get into the practical side, how to record it. And we'll wrap up with some troubleshooting and high-yield exam tips. It's the full roadmap. Right, first things first, before we can even think about finding it or recording it, we have to be absolutely crystal clear on what the posterior palatal seal is. Seriously, getting this definition down is the foundation for everything else we're going to talk about.
Let's really break this definition apart. The PPS isn't a line, it's an area. A zone of soft tissue right where the hard palate transitions to the soft palate. But here's the most important part of that sentence: within physiological limits. This is key. We're not just letting the denture sit there. We're designing it to apply a very specific, gentle pressure. Think of it like a gasket. It creates that perfect seal, and that's the secret sauce for suction and retention.
So where exactly is this magical zone? Like I said, it's not just one single line. It's a whole area that's defined by some very specific anatomical landmarks. Let's take a little virtual tour of the palate and figure out how to map this critical territory. Okay, these are your signposts, your points of reference. Now, the most crucial concept to get your head around is that the PPS is the entire zone located between the anterior and posterior vibrating lines. Those two lines, plus the hamular notches on the left and right, they basically form the complete boundary of the area we're targeting. Now this right here, this slide clears up one of the biggest points of confusion for students. The anterior and posterior vibrating lines are two totally different things, and you find them in two different ways. The anterior line is pretty static. It's just the junction of the hard and soft palate. But the posterior line, that's where the palate actually starts moving when the patient speaks. And this table just lays out perfectly how you find each one in the clinic. And look, if you're studying for your boards or an exam like the NEET PG, or you just want a foolproof way to remember this is it. This little mnemonic is a total lifesaver. For the anterior line, have your patient give you a long, drawn-out ah. For the posterior line, you want short, punchy, energetic bursts, like ah, ah, ah. It's a super simple trick that'll make sure you get it right every single time. Okay, so now we know where to look. The next step is to evaluate what we're looking at. Because, let's be real, not all soft palates are created equal. There's a super useful diagnostic tool called House's classification that helps us predict just how good a patient's anatomy is for getting a great seal. First up is Class I. This is the dream scenario, the ideal palate. You see a really broad, gentle, almost flat transition from the hard to the soft palate. What that means for you is you have a really wide, forgiving area to place your seal. This is by far the most favorable situation you can ask for. Now this is your bread and butter. The Class II palate is what you're going to see most of the time. Here, the soft palate has a more defined angle. It drops off a bit more quickly. So your target zone is narrower, maybe around 3 to 5 millimeters. It's still totally manageable. You just need to be a little more precise than with a Class I. And then you have the Class III. This is the real challenge. The soft palate drops almost straight down like a curtain. There is very, very little movable tissue to work with, which makes your target zone incredibly narrow. For these patients, you often have to rely on a single, sharp, perfectly placed bead for your seal. If you go even a tiny bit too far back, you're going to cause discomfort and trigger a gag reflex. Precision is absolutely everything here. So, we've defined it, we've mapped it out. But why do we go through all this trouble? Let's dig into the clinical significance. Because a properly recorded PPS does way more than just help the denture stay in. The thing is, the PPS is a multifunctional powerhouse. I mean, yeah, of course, it creates that peripheral seal for suction, but it also does something really clever.
It compensates for that tiny bit of shrinkage that always happens when the lab processes the acrylic, which keeps the fit tight. It also acts as a wall, blocking food from getting underneath, a huge patient complaint. And by giving a firm, definite endpoint to the denture, it can actually reduce the gag reflex because the tongue knows where the denture stops. All of this just adds up to patient comfort and confidence. All right, let's switch gears from the why to the how. We know how important it is. So what are the main ways that clinicians actually capture this anatomical area, either in an impression or directly on a cast? Well, there are pretty much two main schools of thought here. The conventional method is where you identify the PPS area in the patient's mouth, and then you carefully scrape the master stone cast to create that seal. It's very direct, and you have total control. On the other hand, you have the fluid wax technique. This is more of a functional method. You add a special warm wax to the tray, put it in the mouth, and have the patient swallow. Their own muscle movements shape the seal. Many people argue this is more physiologically accurate because it's literally molded by how the patient functions. Like any clinical procedure, things can definitely go wrong. But the cool thing about the PPS is that the mistakes are pretty predictable, and, more importantly, they are fixable. This section is all about what to look for, how to figure out what went wrong, and how to fix it. Perfect for the clinic and perfect for your exams. This troubleshooting guide is pure gold. Seriously, if the denture is loose, you might be dealing with underextension. The fix is to add a new seal. If the patient says they have trouble swallowing or their throat feels sore, you've probably overextended onto the moving part of the palate, so you'll need to trim it back. If you scraped the cast too deep, that's over post-damming, you've created a nasty pressure spot that needs to be relieved with a burr. And if the seal is just weak, that's under post-damming, you gotta go back and deepen the seal, either by scoring the cast more or adding more wax. Look, if you only remember one thing from all of this, let it be this. Properly identifying and placing the posterior palatal seal is not some optional bonus step. It is absolutely fundamentally critical for the success, stability, and retention of a maxillary complete denture, period. And I'll leave you with a final thought to chew on. We've talked about the anatomy and the techniques, but how does the type of palate you're looking at, that class 1, 2, or 3, how does that influence the kind of impression material you should choose? Connecting those dots, well, that's the next step toward really mastering this. Thanks for tuning in.